Hello everyone, I'm Alison Burton. I'm a Doctor of Nursing Practice candidate with Maryville University, and this is my scholarly project on the effects of education on marijuana-induced anxiety. I want to thank my DNP committee chair, Dr. Sigmund, who has been fantastic to me as a resource, very knowledgeable from the get-go. My community member, Dr. Strogoff, and thank you to the DNP program leader, Dr. Snell. So a little background on my project. Anxiety fluctuates with the use of marijuana, suggesting it's both good and bad, and suggests it's a friendly plant. Deleterious effects such as problems with the major organ systems and fertility issues contribute to the teratogenic effects of its use. Positive effects can be anorexia, nausea, pain, and muscle spasticity, but declared as a non-dangerous narcotic. Various health effects of marijuana and its metabolites derived from the plant play a role in the alteration of awareness and contribute to neurotransmitter malfunction and a reduction in the volume of the hippocampus. So the purpose of the practice change was to bring awareness through distribution of an educational handout to clients that use marijuana and have anxiety. The handout was then given to them at their first meeting with the provider, and the plan of care was then updated to reflect that it was given. So as the most common illicit substance used around the globe, cannabis use has increased with states' legalization of marijuana. And current literature states that treatment consists of the use of an antidepressant, but coupled with the use of marijuana, it negatively affects and increases the intensity of side effects. Research has shown that the endocannabidiol, CBD, stimulates the serotonin type 1A receptors, resulting in a decrease in anxiety. CBD also enhances the effect of GABA and the 5-HT1A serotonin receptor agonist buspirone, thus acting much like a benzodiazepines that are used to treat anxiety. So, significance of the project is the endocannabinoid system maintains homeostasis, connects our systems and organs of the body, and is implicated in most disease states. Located throughout the body are cannabidiol receptors, most notably CB1 and CB2. THC's intoxicating effect is partly due to mainly working on the CB1 receptor as an antagonist, whereas CBD is negligible in causing psychoactivity due partly to its minimal agonism. Prospective treatments for stress, anxiety, depression, and insomnia are a combination therapy of THC, CBD, or CBD-only medications, reporting relief from various conditions and including pain. Using CBD as an oil tincture or topical rub is in demand, although it is not regulated by the FDA. CBD use has become popular over the last few years due to its low THC content, but due to increased signaling from the cannabinoid receptors, inflammatory secretions from glial cells are reduced, enhancing the analgesic effect. However, CBD appears to be effective for mental health conditions with minimal adverse effects. CBD-only medications reduce stress, anxiety, and insomnia, but show minimal evidence for the reduction of depression. THC CBD medications have a good safety profile for analgesic effects, but still they should not be used in those with depression, psychosis, or suicide due to the possibility of an exacerbation. Drug exposure should be limited as THC and CBD inhibits metabolism enzymes, so appropriate care should be taken. Significance of the project is that cannabis use disorder is rising in popularity as more and more people use marijuana. Treatment currently consists of motivational interviewing, enhancement therapy, as well as cognitive behavioral therapy. Healthcare providers should include screening tools for determination of whether cannabis use is contributing to anxiety symptoms. So screening tools are used to measure a variety of health determinants, but for the project I used the GAD-7 questionnaire for a measure of anxiety, having a reliability and validity sensitivity of 89% and specificity of 82%, making it a very reliable tool. So your research should be free of bias and present information that allows the reader to make an informed decision. It needs to be trustworthy. A well-designed research study includes the following sections: background, purpose, methods, result, discussion, and a conclusion. Random controlled trials. RCTs are the gold standard in nursing research, and 2 were used in this literature review. Second to the RCT and strength for nursing research is the cohort study, and 2 were used in support of the GAD-7 screening tool. Several reviews were compiled and summarized literature to determine and extrapolate information in support of the emerging field of the medical use of cannabis. A cross-sectional design was used due to its prioritization of a larger and more diverse group, rather than performing a longitudinal survey of a smaller group over time. And a pilot study was included in the literature to show teaching skills to manage negative affect elicited a good response. Some weaknesses of evidence: self-reported measurements, bias findings, and cross-sectional designs do not explore causal relationships between variables. There was a study where convenience sampling was used that impeded the variables, and one of the studies had small sample sizes, mostly of females, which is an example of weakness because only one was included. And there was a study that a systematic review was not made because high-potency THC was not studied. Gaps and limitations occurred because 2 of the studies were missing adequate information. One of the studies hypothesized something, and the other study just focused on the problematic and not the recreational user. So, intervention education. It has been estimated that 3 in 10 people use marijuana, and suffer from cannabis use disorder, and those who started using before the age of 18 risk damage to the developing brain. So a need existed to outline the health determinants that can occur in the body when marijuana is used, and to extrapolate and compile information from previous evidence-based studies. Due to marijuana still being considered an illegal drug in many states, guidelines for the treatment of recreational cannabis did not exist. Safety considerations include coordination problems, dizziness, disorientation, euphoria, drowsiness or fatigue, dry mouth, nausea, and GI upset. Therefore, regular monitoring is needed. So a need currently exists for practitioners to design and implement a social marketing campaign or curriculum infusion to correct misconceptions about marijuana. So I use the health promotion model by Nola Pender for my theoretical framework. The first step is the individual characteristics and experience, where the client sought care and revealed use of marijuana. The second step is behavior-specific cognition and affect, where the client revealed their level of anxiety. And third, in framework, is behavioral outcomes, where the quality of life was enhanced. So a good methodology section outlines the approach to the information. This was a qualitative data analysis of a retrospective review of pre- and post-GAD-7 screen questionnaire with a sample size of 120. The information was ran through SPSS using the paired sample t-test. The inclusion criteria for the participants' EMR consisted of the following: age requirement of 18 to 59 years of age, having a diagnosis of anxiety, fulfilled both the pre- and post-intervention timeframes, verbal education of the intervention was performed, documentation of the educational pamphlet was given, documentation of post-intervention visit for exacerbation if needed, and the exclusion criteria was the age requirement was not met. They did not have a diagnosis of anxiety, and both the pre- and post-intervention visits did not occur. A sequential inclusion and exclusion process was continued until the amount of 120 charts of the EMRs were achieved. So as you can see in Table 4, the power analysis of 1.00 was achieved. However, the Maryville University statistician determined that 41 charts would need to be reviewed for the appropriate power analysis of 0.8 to occur. However, 120 charts were reviewed, resulting in the power analysis of 1.0 and the pair sample t-test. The t-test was used to show a difference between a matched pair consisting of two dependent variables. So as you can see from Table 2, there was a significant difference in pre- and post-education GAD-7 scores, suggesting more significant evidence to reject the null hypothesis influenced by the large sample size. The t-value represented the size of the difference in the variation relative to the sample data. So simply put, the bigger the number, the greater the evidence of a significant difference. Therefore, if the number is closer to 0, it is likely that there is not a significant difference.
The project has a meaningful practical significance due to its large effect size. A p-value of under 0.001 was reported, indicating a significant difference. Due to large effect size, the detection of the degree of variability was expected and can be found in Table 2 as well.
So as you can see in Table 3, pre-education GAD-7, a mean of 12.58 and a standard deviation of 5.235 indicated that those who ingest marijuana report anxiety. And then the post-education GAD-7 with the mean of 5.235 and a standard deviation of 4.902 shows a decrease in anxiety when the use of marijuana is decreased or discontinued altogether. So the standard deviation indicates the average amount of variability. That's how far each is separated from the means in the reported data. So differing from the bar chart where data is compared, the histogram displays a distribution of variables. So figure 1 represents a pair sample t-test for its scholarly project, supporting evidence of a difference in GAD-7 scores pre- and post-education. The histogram was used since the scholarly project sample size was more than 100. So the project found a statistical difference in the measurement of the GAD-7 screening tool between the pre- and post-education scores. The significance level 13.954 calculated with the pair sample t-test was robustly greater than the recommended significance level of 1.00. The results were calculated using a total sample size of 120. So minimal limitations did occur with the project implementation. Patients could have embellished on their use of marijuana or not attended their post-intervention follow-up appointment. Sustainability was that the project was duplicatable by another, and generalizability is that that's where that minimal limitation, because it was poorly generalized, it was to a specific population. But the study was rigorous. You could rely on the results, and it wasn't biased because no error was introduced at any point in the study. But there was an unintended consequence where a patient voiced their displeasure on the education. So post-implementation insights, there were no real barriers to the study because it was located in a state where marijuana is legal for personal consumption. So this facilitated communication between the client and the provider. And the facilitators were Maryville University with their IRB approval, the study location with the clinic approval, and evidence-based literature used to guide the student researcher. So interpretation was that it was hypothesized that there would be a reduction in GAD-7 scores once the client patient realized how marijuana contributed to their anxiety and other health determinants, so they would question their continued use. The data showed that there was a hearty significance found. So, some implications of the project. For the practice and future research, it's recommended that literature-based information is taken one step further. The project revealed that if you use marijuana, anxiety increases. If you stop using marijuana, anxiety decreases. Healthcare policies are in place to provide safe, cost-effective care and improve overall patient health care. And quality was implemented through the standards of being thorough, relevant, accurate, and original, having a clear hypothesis to ensure transparency. Safety was completed through the appropriate approvals for the study with both the IRB and the clinic. And another thing of safety is city training was completed by the student researcher. However, no human subjects were involved, so it was a retrospective chart review. So this project suggests that if you decrease or stop using marijuana altogether, your anxiety will decrease. Literature supports biphasic effect that THC induces anxiety, contrasting with CBD that reduces anxiety, further supporting the robust difference between pre and post education GAD-7 scores. It is recommended that the evidence-based educational handout be given to every client or patient seeking healthcare services so that they are able to make an informed decision on the continued use of marijuana. The healthcare plan of costs can be reduced when a client patient does not further need an anxiolytic medication because using marijuana has ceased. So this project was deemed successful and thus will be continued at the mental health clinic. The GAD-7 screening tool is already being used for each client patient, and that will continue. It's a relatively low-cost intervention to continue and would not affect the financial stability of other mental health clinics in a major way. Plan for dissemination. Now that the project has concluded, the next step is disseminating this results to other colleagues and stakeholders.
So that brings me to
And
any
these
final
are the
questions
references
that you may
that
have.
were used in this oral presentation.